So the second most common question that I get asked when I talk to patient groups is about tiredness. This is a complicated subject, and so I'll only be able to explore part of it. But there's no doubt that having a lymphoma, receiving chemotherapy or radiation or immunotherapy, that those are associated with fatigue or tiredness. But there's also no doubt in my mind that having any crisis in your life, whether it's healing up from an automobile accident or a broken leg or getting over a bad case of influenza or any other physically stressful event in your life, is also frequently associated with tiredness. And so it's difficult to separate out which parts of what is going on are the things that are the most contributory to the tiredness. So at the time when the disease is being figured out and before it's being treated, certainly the lymphoma can be a source of tiredness, and the obvious solution to that is to get rid of the lymphoma or the leukemia or the other lymphoid cancer, or suppress it as effectively as one can. During the course of treatment, it is very stressful for your body to deal with the side effects or potential side effects of chemotherapy, radiation, immunotherapy. And so it's clear that tiredness may be a complicating part of that phase of your management. And the only real solution to that is to get done with the treatment. Once there's no longer a necessity to take the treatment and have its associated toxicity, the tiredness should resolve. Beyond that, there is a period of time when it actually takes a while to get life back together again, to get over the emotional stress of having gone through a major crisis like this. And people have to have some patience and allow themselves the time to not only physically heal, but emotionally heal from the trauma of having a serious disease. And there I have no better solution than to say that time does make some things like that better, and getting on with life does improve things. But none of those answers are very helpful to this individual who's asked the question, because the real question here is, all those things have been done. My treatment's done, my lymphoma's gone, I'm not worried about it anymore, and I'm still tired. And now we get into an area that is, I'll have to admit, very poorly understood. I think there's enough evidence, though, to make it clear that for reasons we don't understand, even in that situation, when everything should be finished and over with, there is a kind of tiredness that can be bothersome for people. This is very variable. I have patients who go all the way back to playing rugby, soccer, running marathons, running big companies, doing all sorts of things without the least bit of tiredness after their treatment is over, all the way through to people that have to quit their current job and they just can't do it anymore because of this permeable or permeative type of tiredness. And there doesn't seem to be any clear accounting for this to figure out what it is that causes that to happen. The best I can do is to try to deal with any other causes of the tiredness, so reduce the amount of emotional stress and even physical stress that there might be present in your life, simplify things as much as possible, get adequate amounts of exercise so that your body's properly looked after, eat a nutritious diet, all pretty motherhood and apple pie type of things to do, but they do make good sense. And then if the tiredness persists beyond that, about all that I can suggest is that you start having to make life adaptations. And there may simply be a necessity to rest sometime during the day, or not do a particular job, or at least do it at a slower pace, or whatever. You have to adapt your life to the residual tiredness that's present. Fortunately, with the passage of time, that tiredness often does improve. And so having some patience to give your body the time to get out to that time when things will improve can help. But I have to admit that for some people, this can be a persistent problem, and it needs more scientific investigation and better understanding before we'll be able to figure out what we might be able to helpfully do about it. This is a question that's going to get me into some of the technical aspects of managing lymphoma. And to repeat the question, it's what is the usefulness, what are the chances that it will work of receiving an allogeneic bone marrow transplant or stem cell transplant for follicular lymphoma. So first let's make sure we all understand the terms. So follicular lymphoma is the first or second most common type of non-Hodgkin lymphoma and a common one to encounter. It typically involves widespread throughout the body, and so patients tend to have an advanced stage of the disease, but it also typically has a fairly indolent course. Changes in this disease occur slowly over months to years. Allogeneic means receiving the source of cells for a stem cell or bone marrow transplant from somebody else. And stem cell transplant is just that. We're putting cells into a person's body that are capable of regenerating their blood-making cells or their immune system. So why would we ever do something like that? Well, it turns out that some lymphomas in some circumstances won't get better when one uses ordinary doses of chemotherapy for them. But they will get better if you use a much higher dose of chemotherapy, typically 10 times as much chemotherapy. The problem with giving that much chemotherapy is that it will have the negative effect of drastically injuring blood-making cells or bone marrow cells in a person's body. And if you don't do anything else, those cells not working will put the person in danger of dying because they simply aren't making enough blood cells. So the technique that's been developed to deal with that is to give a person their very high dose of the chemotherapy and then right afterwards put some stem cells back into their body that can then grow inside their body and replenish those missing blood-making cells. And a simple way to do this is to have taken some of those cells out of that person before the high dose of chemotherapy. So you can take some bone marrow cells or special stem cells that are found in the blood, taken out with a blood separating machine, store them away, give the high dose of treatment, and then put those cells back in again. That's called an autologous stem cell transplant. So the source of the cells is the person themselves. They're getting their own cells back. That's very attractive because they're likely to tolerate those cells just fine. They are their own cells, and so there's no problem with putting them back into their body. But when we talk about an allogeneic transplant, so now we're using cells that are coming from somebody else's body, there's two risks. The first risk is that the recipient, the person receiving the cells, that their body will reject these cells. Just as a skin graft might be rejected or a kidney graft might be rejected if you don't do the right things, this set of stem cell transplant cells might be rejected and kicked out of the body. So it's necessary to suppress the natural immune reaction that a person would mount to these foreign cells, and that means taking complicated and medications for prolonged periods of time to suppress the innate immune response. But there's even another danger, and that is that the new cells that have been put in, because they're fully functional immune cells, they may attack the body that they've been put into. And then we have the graft, the cells that are being put in, attacking the recipient, the host. We have a disease called graft versus host disease. So the situation, as you can see, starts to become very complex. We have to manipulate both the person receiving the cells and the cells that we're putting in such a way that we block the likelihood that the graft will attack the recipient or that the recipient will reject the cells that are coming in. But we can't block things too badly or the cells won't even take. They won't even grow into new blood cells, blood-making cells. So one doesn't think about using a technique like this unless a whole collection of other attempts to control a disease have already been used and they're simply not working.